Hi everyone. Today's video is going to be about the management and treatment of liver cirrhosis, and that kind of feeds into my first disclaimer. Only going to be talking about management today. Not going to be going super in depth into pathogenesis, physiology, etiology, and so on. So I do recommend you have at least some basic level of understanding, like background of those areas for cirrhosis, just so you don't feel like lost in this video because I do go kind of fast in this one. It definitely is going to feel like rapid fire. Sometimes maybe even eclectic. I'm going to just be jumping from point to point. Sometimes they're not even going to be related to one another. If that feels like too fast or eclectic too, please like feel free to rewatch the video multiple times or pause at certain points. Or just let me know, like, if you feel like it's actually too disorganized, please leave a comment below. I'm always open to feedback. But just with all that out of the way, let's just jump right into it. Once you've established a diagnosis of cirrhosis in your patient, one of the first things that should come to mind for you is, what do I need to do to manage this patient acutely? And what do I need to do to manage them chronically? So on the acute side, that's mostly going to pertain to complications of cirrhosis. These are some of the many complications of cirrhosis. Doesn't include all of them, but these are some of the most important ones that you should keep in mind for step two. And then for long-term management, that's mostly going to be managing symptoms of cirrhosis and or the underlying disease or cause, if you can identify one. So for a symptomatic management, that's going to be achieved through volume management of the patient's volume status. So that's going to occur through diuretics and a low sodium diet and even paracentesis if needed. As for managing the underlying disease, it depends, right? So if the patient has alcoholic cirrhosis, you have to manage the alcoholism. If the cirrhosis is secondary to hep C virus, you have to manage that as well, and so on and so forth. So let's start by going more in depth into the long-term management. And again, this is high yield rapid fire, so sorry if it seems like a little like eclectic or disorganized, but okay, first things first. The first line diuretics for volume overload and cirrhosis are furosemide, otherwise known as Lasix, plus spironolactone. These are very rarely, if ever, used as monotherapy for cirrhosis. You're almost always going to see them used in conjunction with one another for cirrhosis. And part of the reason is because one of these is potassium wasting and the other is potassium sparing. One of the benefits of that is obviously in a lot of your cirrhotic patients, a lot of them might actually be dealing with hypokalemia already. So you don't want to throw off their electrolytes even further. Second point, in alcoholic cirrhosis, abstinence from alcohol is the single most effective intervention you can do to reduce portal pressure, inflammation, and fibrosis. So even though we already mentioned the diuretics and low sodium diet, even though that's part of the first line management, and they might have an effect on the portal pressure, they don't really have an effect on the inflammation or fibrosis that's going on. So the abstinence of alcohol is going to improve the inflammation, fibrosis, pressure. It's also going to improve the ascites and the mortality rate overall. So in other words, the best thing you can do for alcoholic cirrhosis is stop drinking alcohol. So let's say you have an alcoholic cirrhosis patient and you want to try getting them to quit drinking. So in addition to behavioral therapy, what can you give them that will reduce their cravings? For anyone who said naltrexone or camprosate, you would be correct. Both these medications reduce cravings for alcohol use syndrome. So, all right, let's say you prescribe naltrexone or camprosate, and you manage to get your cirrhotic patient to stop drinking alcohol. Awesome. What's a big thing you need to watch out for now? That's right, alcohol withdrawal. And what's the main treatment for alcohol withdrawal? Benzos. So specifically, what are the three main benzos that you can safely use in patients with cirrhosis? And the answer here is oxazepam, temazepam, and lorazepam. And this can be remembered through the mnemonic. Most people go with LOT. I personally like out of the liver because it just reinforces the idea that these are the three benzos used for liver disease, for cirrhosis. All right, now let's move on to the high yield points for acute management. So the primary management for hepatic encephalopathy, Remember, this is one of the main complications of cirrhosis. So the primary management for hepatic encephalopathy is going to be on two fronts. Number one, you need to make sure that you are resuscitating your patient with IV fluids and repleting any electrolytes, any electrolyte deficiencies. Secondly, you want to be giving them ammonia reducing agents. Does anyone know what the two main ammonia reducing agents are for hepatic encephalopathy? So the answer here would be lactulose and rifaximin. So the first line is lactulose. Always good. Lactulose, lactulose, lactulose. That is the one that you should be thinking of first thing for hepatic encephalopathy. If you may recall, lactulose is a laxative, and in this case, it is beneficial for hepatic encephalopathy because it gets metabolized into these acidic metabolites, which acidify the GI tract, and that converts ammonia to ammonium, and ammonium is not absorbable through the GI tract. So it gets trapped in the intestinal lumen and excreted out the body. So there's no more accumulation of ammonia in the bloodstream. The second line, maybe if lactulose is like if the patient's not responding to lactulose, the second line would be rifaximin. And for those of you who may recall, rifaximin is an antibiotic. And so it will work by reducing the amount of ammonia producing bacteria that are present in the gut. This is lower yield, but neomycin is another option for a similar reason. But it's low yield because it's only really used for patients that are non-responsive or have low tolerance of both lactulose and rifaximin. All right. Oh, I guess I didn't block this one out. Oh well. But what procedure is used to establish the diagnosis of spontaneous bacterial peritonitis? The answer is, of course, paracentesis. That part makes sense. This is lower yield, but might just be helpful to know. This is a diagnostic criteria. Notice how it's with or without positive fluid cultures, right? So you're always like pragmatically, you're always going to order a gram stain and fluid culture of the ascitic fluid, but because it's so low sensitivity for SBP, they are not required for diagnosis. So in order to have a patient with SBP that you diagnose with SBP, they essentially only have to have like a fever, honestly low grade fever, maybe altered status, a source of infection, and PMN over 250 in the ascitic fluid. The fluid culture could be negative, and that shouldn't significantly deter you from your diagnosis. And paracentesis should be done before starting antibiotic therapy. This is an Anki card that I found might be useful too. Just gives extra context. So for SBP, when you have a patient who you're suspicious for having SBP, first things you should be doing is do a paracentesis, then immediately start broad spectrum antibiotics and give IV albumin. All right, next question. What's the likely diagnosis in a cirrhotic patient with decreasing GFR, a normal urinalysis, and lack of improvement with IV fluids, and no other renal dysfunction? The answer for this is hepatorenal syndrome. Let's see right here. So common inciting factors for hepatorenal syndrome include SBP and GI bleeding. Other potential inciting factors could be excess use of diuretics or lactulose, which can cause a volume depletion. And so the mechanism behind this is patients with cirrhosis, they're developing portal hypertension. And because of that, that's going to induce the release of nitric oxide in the surrounding area. And that causes vasodilation of the splanchnic blood vessels. So that causes a this causes a reduction in the effective arterial blood pressure, which leads to decreased renal perfusion, which then stimulates hyperactivation of RAS. But that only is sustained for so long, and eventually this is going to progress to renal failure. So this is kind of one of the parts that took me a while to fully understand. So take your time with this. This is a figure that might be more helpful. You can pause the video if you want to take a quicker look at it or take a screenshot. But for hepatorenal syndrome on labs, you're really going to see it's going to seem like any other case of AKI or renal failure. So you're going to have elevated BUN, you're going to have elevated creatinine. You're also going to have metabolic acidosis and hyperkalemia because, again, those kidneys, um, even though the RAS is initially increased, which would cause increased potassium excretion, over time, that's not enough to compensate. And so the kidneys just start failing. And so they start retaining potassium. So management of this cirrhosis complication is not easy, doesn't have a great prognosis. Hepatorenal syndrome, especially if you don't catch it early enough, it's usually going to be refractory to volume resuscitation and albumin. So liver transplant is unfortunately the only definitive treatment. And this figure, you can kind of go more into it on your own time, but this kind of just shows how hepatorenal syndrome, it reinforces how the urinalysis is going to be mostly normal, and how if you're suspecting hepatorenal syndrome, but then the patient improves with IV fluids and albumin, then that tells us that they were probably just volume depleted. But if the patient does not improve with those measures, that confirms our diagnosis of hepatorenal syndrome. And that tells us that this is what's going on and that the patient's going to need a transplant. All right, so next question. What pharmaceutical therapy is recommended for prophylaxis of non-bleeding esophageal varices? If you said non-selective beta blockers, you would be correct. It is important to know that even though beta blockers are super important in the management of esophageal varices, specifically long-term management, it's mostly a prophylactic measure, right? So if you have esophageal varices that are actively bleeding, then the standard treatment is going to be endoscopic ligation, octreotide, which I believe is a somatostatin analog, and antibiotics. The beta blockers, it's mostly for, uh, again, like prevention of either the first bleed or rebleeding. All patients with cirrhosis, sorry, are at increased risk of additional complications, as we've, kind of mentioned a few so far. They need to be screened for two complications in particular: the varices, as we just mentioned, and hepatocellular carcinoma. This is super, super high yield. These are the two main things that cirrhosis patients are going to be getting screened for. So you screen for esophageal varices with an upper GI endoscopy every 2 or 3 years, I think is the average when I looked it up, but this is fairly low yield to know the interval. Just know the upper GI endoscopy. And then you screen for hepatocellular carcinoma with an abdominal ultrasound. This is high yield, especially for ambulatory care or primary care. For patients who are asymptomatic, you are going to be doing standard screening with an abdominal ultrasound every 6 months. Every 6 months, every cirrhotic patient, no matter whether they're symptomatic or not. So what's the most appropriate next step in evaluating a patient with cirrhosis, new onset ascites, and stable variceal bleeding? The answer is abdominal ultrasound. And the reason behind this is because if you have a patient who had cirrhosis and they were not symptomatic for ascites before, and now they have this new onset ascites, that's going to raise concern for either hepatocellular carcinoma or a clot in the portal system. Because if you have this new onset ascites, that's telling you that there is this new obstruction in the portal system that was not there before. All right, so take a minute, quick breather. We kind of just like ran through all that. But whenever you're ready, we're going to go through some full-on practice questions from an undisclosed source that rhymes with New World. But just don't copyright strike me, please. But anyways, yeah, let's just get started. A 41-year-old man comes to the office due to progressive abdominal distension for the past 3 months. He states that his abdomen feels heavy, and although uncomfortable, the feeling has not been severe enough to interfere with activities of daily living. The patient drinks 8 to 10 beers a day and was hospitalized for alcoholic hepatitis 2 years ago. Vital signs are within normal limits. BMI is 26. Physical exam shows no jaundice. Heart and lung sounds are unremarkable. The abdomen is soft with mildly tender liver edge palpable at the right costal margin. There is no extremity edema. Abdominal ultrasonography demonstrates nodular liver with coarse echo texture and ascites, which the following is most significant would most significantly decrease both liver inflammation and portal pressure in this patient. So the answer here would be complete alcohol cessation. Um, Notice that, so technically this patient doesn't have cirrhosis, I don't think. They refer to it as alcohol-associated liver disease. You can tell, I mean, he's like fairly asymptomatic. I mean, he does have ascites, but he has no jaundice, and he hasn't had any interference with daily living activities. But regardless, this is whether you want to qualify this as cirrhosis or not, it's alcohol-associated liver disease to some capacity. And as we established, cessation of alcohol use is the best thing that you can do in these patients from a perspective of inflammation, of portal pressure, of mortality, and so on. Next question. A 56-year-old man is brought to the emergency department due to worsening confusion. He's been forgetful and irritable for the past several days, and today the patient's wife found him in bed, lethargic and disoriented. He's had no fever, headache, abdominal pain, or vomiting. The patient drinks half to a full pint of vodka daily and was hospitalized previously for acute alcoholic pancreatitis. Temperature is 98.4 Fahrenheit. Blood pressure is 116/68. Pulse is 84. The patient is somnolent but awakens to physical stimuli. He follows simple instructions but is not oriented to time or place. His speech is slurred. Lung fields are clear to auscultation. Cardiac exam reveals normal heart sounds with no murmur. The abdomen is moderately distended with shifting dullness. The patient moves all extremities equally and has a flapping tremor of his outstretched, dorsiflexed hands. Deep tendon reflexes are 3 plus diffusely. Laboratory results are as follows. So, which of the following treatments will most likely improve this patient's mental status? All right. Yeah. And please feel free to pause. It goes without saying, pause at any point if you need more time to think. So the answer here was initiate lactulose. I didn't make too many highlights here. There isn't too much that would be confusing with this question. You just have a cirrhotic patient who is altered. But I did notice the second most popular question was E. So anyone who chose E, they were likely thinking down the route of a Wernicke encephalopathy, which can be seen in alcoholic patients. But in addition to the confusion, you would also have ataxia. I don't think this patient had ataxia, but regardless, he definitely did not have nystagmus, which is pretty big for Wernicke encephalopathy, and also the asterixes is generally not present in Wernicke, but is present in a hepatic encephalopathy. All right, next question. A 38-year-old man comes to the office for evaluation of bilateral progressive hand pain with intermittent swelling over the past 6 months. The patient has no other symptoms or history of trauma or family history of arthropathy. Medical history is significant for type 2 diabetes mellitus, for which he takes metformin. Vital signs are normal. BMI is 24. Exam reveals mild swelling and tenderness over the second and third metacarpal phalangeal joints bilaterally. There's no muscle weakness. X-ray reveals joint space narrowing and chondrocalcinosis involving the second MCP joints with osteophyte formation at the second and third metacarpal heads. Serum alanine and aspartate aminotransferases are elevated, which the following therapies would be of most benefit to this patient. All right, take your time, think about your answer. Answer here is a phlebotomy. This was kind of an unfair question. This was a toughie. I'm not gonna lie, but it's just good practice. So it is a tough question, but once you know what's going on, it is simple in the sense that you only really need to know 2 main points of information to connect the dots here. Number 1 is that hereditary hemochromatosis is a cause of cirrhosis. And number 2 is hereditary hemochromatosis has the triad of jaundice or liver involvement, diabetes, and arthropathy. So let's go through it like step by step. You would so you would have to know so for this question you would have to notice that this patient he's a fairly young guy, like he's in his 30s, and he's presenting with this like new onset arthropathy and swelling without an identifiable cause. And again, he's like fairly young with a totally normal BMI, yet he has type 2 diabetes mellitus. So immediately, um, you could be thinking like bronze diabetes. This is HHS. And they kind of go more into depth with which joints are involved. MCP joints are very commonly involved in HHS. There's no muscle weakness, so that immediately rules out certain uh, radiculopathies or a myositis, like dermatomyositis and polymyositis. There's also chondrocalcinosis. That's also a big thing for HHS, and then the elevated liver enzymes. So if you guys want to read through this, to rule out A, B, or D, you can pause that. But I think other than that, yeah, the chondrocalcinosis, the symptoms. Oh yeah, just know, I mean, HHS, the arthropathy in HHS, it's similar to osteoarthritis. It's just going to be in younger patients, and it's going to have the chondrocalcinosis as well. And aside from symptomatic management, really phlebotomy is the only thing that's going to help these patients. All right, next question. A 43-year-old man is being evaluated for erectile dysfunction, which has been progressive over the past year. He has no other symptoms except some fatigue that he attributes to his intense work schedule. The patient drinks 1 to 2 beers every day after work and has a 20-pack year smoking history. He has not used recreational drugs or take over-the-counter medications. Vital signs are normal. BMI is 29. Skin exam shows brownish skin pigmentation, most pronounced over the face and both arms. The abdomen is soft and non-tender without organomegaly. Cardiopulmonary exam shows no abnormalities and there's no peripheral edema. Laboratory results are as follows. If untreated, this patient is at increased risk for developing which of the following complications. All right, and pause the video if you need extra time. So the answer would be hepatocellular carcinoma. We don't have to dwell on this too much. Just if you're able to recognize that this patient has cirrhosis and you know that cirrhosis is such a huge predisposer for liver cancer, you're golden. If you're worried that about like, oh, maybe like maybe I wouldn't be able to identify this as cirrhosis on the test, you would be able to see. So there is like, so you know that there's skin pigmentation. You see that there's erectile dysfunction and there's liver involvement. So those three things together, oh, plus like the smoking history. Those three things are going to increase your suspicion for uh, cirrhosis and HHS. Oh, right, I didn't mention the blood glucose that will contribute to HHS. So those three things, again, it's the bronze diabetes. If you know that mnemonic and you know that HHS is a common cause of cirrhosis, I think you'll be golden here. I did want to address C. 12% of people answer that. Addison's disease is a fair possibility because of the hyperpigmentation in this patient. However, as your world says, Addison's disease, because it's an adrenal insufficiency, it causes hypoglycemia, not hyperglycemia. And I think I left a note. Right, hypogonadism is also not common in Addison. The erectile dysfunction. It's not as common in Addison as HHS. A 60-year-old man is brought to the emergency department due to progressive lethargy. The patient has a history of alcoholic cirrhosis and was recently seen in his primary care provider's office for increasing abdominal distension and leg swelling. His wife says that the swelling improved slightly after furosemide and spironolactone, but for the last 2 days, he's been confused and irritable. The patient slept most of the time, has not eaten. Temperature is 98 Fahrenheit, blood pressure 96/50, pulse is 96. On exam, the patient appears lethargic but is arousable. He's not very cooperative and at times is agitated. Mucous membranes are dry. His outstretched hands exhibit a flapping tremor. The abdomen is non-tender and distended, and shifting dullness is present. Bilateral lower extremity pain edema is present. Still cold blood is negative. Laboratory results are as follows. Which of the following is the best initial treatment for this patient? So if you chose repletion of potassium, you'd be correct. This was a tough one. I'm surprised like 55 pe people got it right, or 55% of people got it right. Um, uh, just remember the point I made of the twofold management plan for hepatic encephalopathy. So it's not just the ammonia reducing agents. It's also just the standard baseline treatment of giving them IV fluids and repleting their electrolytes. And if you look at this patient, he has notable hypokalemia. And it's just that none of the other answers make sense. That's kind of like the thing here. Oral neomycin, we did mention that. That is an option for hepatic encephalopathy. It's just not um it's not first line by any means. It's third line. And so we wouldn't really jump to neomycin as an initial treatment because it's just not, you know, it's reserved for patients that are very refractory. And then for some people said dietary protein restriction. That's fair too, because again, he has um, hepatic encephalopathy, so you would think, okay, that's high ammonia. So we want to reduce the ammonia levels by reducing his protein intake. But the thing is, most patients with cirrhosis are malnourished, so restricting the proteins intake can actually end up having a negative effect rather than a beneficial effect. Um, Oh, I guess this is important to know though. You do restrict a protein in a patient's diet if they received tips, and that leads to my next point. You would not uh, do tips in this patient. He has hepatic encephalopathy, so which is caused by hyperammonemia. Tips is going to increase the risk and severity of the hyperammonemia. And that's because when you perform tips, you are going to be bypassing the portal circulation through the liver that is responsible for detoxifying the blood, for detoxifying the ammonia. Um, and I think that's all I want to say for this question. All right. A 52-year-old man is admitted to the hospital due to fatigue and abdominal discomfort. The patient has had no nausea, vomiting, constipation, or diarrhea. Medical history is significant for cirrhosis due to chronic alcohol use. Medications include spironolactone and furosemide. He had an inguinal hernia repaired 20 years ago. Temperature is 100.2 Fahrenheit. Blood pressure is 102/68, and pulse is 106. The patient is awake, alert, and oriented to time, place, and person, but is unable to successfully perform a time connect the numbers test. Auscultation of the heart and lungs is normal. Abdominal examination shows moderate ascites with diffuse tenderness to palpation. There's no rigidity or rebound tiredness. Bowel sounds are decreased. Rectal exam is normal with guaiac negative brown stool. Abdominal x-ray reveals dilated loops of small and large bowel with air in the colon and rectum, which the following is most likely diagnosis in this patient. SBP is the correct answer. This one is fairly straightforward. You have abdominal symptoms, acute abdominal symptoms in this cirrhotic patient with a low-grade fever. Um, let's see, with a decreased bowel sounds and dilation of the small and large bowel. So for people who said SBO, that's a fair thought. It's just that you would only see dilation of the small intestine SBO because the obstruction is in the small intestine. So the large intestine should not be distended. And in SBO, you can see air in the colon and rectum. You may or may not. But the main thing is the dilated loops in the large bowel. And also SBO, bowel sounds are generally increased and high pitched, particularly in the early stages. They might decrease later on, but this patient, I believe, is pretty acute. I think his symptoms started recently. I don't think they gave us an exact time frame, but yeah. That's all I want to say for this question. So crap. Okay, this is another long one. I'm just gonna let you guys read this. So just pause the video and read through it. But I will go over the answers afterwards. So the answer for this one was A, abdominal ultrasonography. Um, the only thing to keep in mind here is that this patient has had stable cirrhosis, but he's now presenting with new onset ascites. Now remember, new onset ascites in a cirrhotic patient is going to increase our concern for a potential obstruction in the portal system. And so we want to do an abdominal ultrasound to see, does this patient have liver cancer or thrombosis in the portal vein? The abdominal ultrasound will show you both of those. All right, and you guys can pause the video and read through this one. I'll show this for the question and then scroll down for the answer choices. So the answer for this was hepatocellular carcinoma. Um, again, just kind of speaking to the fact that cirrhosis is going to increase your risk for having liver cancer, and that can present as new onset ascites. Um, and that's about it. For the other answer choices, few world mentions. So I think what some people were thinking was like, this is a female specifically, so who has a hepatic nodule in her liver. So they were thinking, oh, is this a hepatic adenoma, which has a strong association with females? But that is generally younger females. Focal nodular hyperplasia, I don't think has a gender bias, but regardless, in either case, they don't increase the risk for developing liver failure, like liver decompensation, like cirrhosis does. All right, so you can pause the video and read through this question. So the answer for this one would be loop diuretic use. Um, the one of the possibilities could be hepatorenal syndrome because you have this patient who has a cirrhosis who's now presenting with some kind of potential like kidney injury. But the main thing to just bear in mind here is that hepatorenal syndrome is going to be acidosis and hyperkalemia, not alkalosis and hypokalemia, which is what you see in the loop diuretic use. All right, and you can pause this video and take a read through. And the correct answer is furosemide, spironolactone. Pretty standard here. Just make sure that they are given together. You don't give furosemide alone. You can technically give spironolactone alone in certain patients in which you have a um, stronger concern for hypokalemia, but otherwise you're going to be giving these together for cirrhosis patients. All right. Feel free to pause this and read through this question. And revealing the answer, it is E, splanchnic vasodilation. Not much to this one. It's just a matter of understanding the mechanism behind the fluid buildup for ascites and hepatorenal syndrome in cirrhosis patients. You have the portal hypertension that's inducing the nitric oxide release, and that's what's causing the splanchnic vasodilation, which is resulting in this third spacing. All right, and on to the next and last question, I believe. An answer here is similarly the cirrhosis-associated splanchnic vasodilation. This is the mechanism that's underlying both ascites and hepatorenal syndrome. Um, if you can understand this figure, that will go a long way for these questions. Outside of that, just to help make the distinction between volume depletion and hepatorenal syndrome in cirrhotic patients, just know that this patient who had an AKI, he that AKI did not improve when he was given saline and albumin. So that is what tells us that this is hepatorenal syndrome and not merely volume depletion. All right, and that concludes all the practice questions we have today. I hope it was at least a bit helpful. If you have any additional questions on anything we discussed today, again, please feel free to leave a comment down below, and I'll get back to you. And if you have any suggestions for any other topics you'd like to see in the future, just let me know as well, and I can get working on them. But until next time, I'll see you guys.